Welcome back to the Band-Aid Man OC, your source for EMT, EMR, and sports med education. Today we're going to be going over Chapter 28, Musculoskeletal Trauma from the Emergency Care 13th edition by Dan Limmer and Michael O'Keefe. Go ahead and follow along with your PowerPoint if you have one in front of you, and you can also follow along with your textbook if you're in my class. If you're not in my class, feel free to take notes, and as always, look down below for any answers to any of the questions that you may have, as well as questions from students in my classroom, so that we can give you a bit more clarity on what we're talking about today. Today, we're going to be talking about the following topics. We're going to break down the musculoskeletal system. We're going to share general guidelines for emergency care for musculoskeletal injuries, and we're also going to go more in depth with emergency care for very specific injuries. Now, the musculoskeletal system is something that most of you have been introduced to just as a result of going through an anatomy and physiology course or through some of the earlier chapters in your EMT text. Typically, by this point, you've been introduced to the concepts of long bones versus irregular bones, flat bones, and so on and so forth. But it is a good idea always to review before we start talking about new concepts so that we can build on the education that we already have. Now, it's important that we understand what each of these structures is for, so let's break that down really quickly. The bones that we have in our body provide the framework. It is the structural component that helps us stay upright as well as gives us our general shape. Our joints assist with bending between those two bones and between the bony structures of the body. The muscles aid in movement as well as the ability to keep ourselves in an upright moving position. Cartilage provides for flexibility, and it also builds out structures that don't typically need to have hard bony structures, such as the outer component of our ear, the tips of our noses, and parts of our rib cage. Our ligaments allow us to connect bones to one another, and tendons allow us to connect muscles to bones. So let's talk about bones. Bones themselves are formed of these dense connective tissues, and they're dense connective tissues that truly are living, breathing organisms. They have blood vessels that run through them. They are responsible not only to make up the structure of our body, but also to act as a hard pathway from A to B. And they also have a very unique ability to heal themselves when they've been broken. That's not 100% all the time, but for the most part, our bones will be able to build themselves back up after a fracture. And unless we have some type of disease that would not allow it, the bones will actually become slightly stronger after a fracture. So this diagram is a little difficult to see. You may want to zoom in, but it is a breakdown of the skeletal system, and it's actually breaking down some of the larger bony structures. We're not going to be breaking down the hundreds of bones in our body here. We're going to be focusing more on the bones that we would run into that become injured in any type of typical EMS response. So if you're looking for a thorough breakdown of all the bones of the human body, this isn't going to be that type of PowerPoint, but we are going to be talking about very specific types of injuries. So stay tuned. Your bones have classifications, and the 4 classifications that you should really know as an EMT are as follows: irregular, long, short, and flat. Now, because I teach sports medicine and because I have students that don't necessarily have a desire to work as an EMT, they have much larger, grander design for their career plan, and they want to be doctors, or they'd like to be athletic trainers, or they want to work in a specialty of medicine. I decided to throw in the sesamoid bones. These are bones that are typically small, and they aid in movement, and one of the most recognizable sesamoid bones that we have is the patella. It really isn't referenced very often in EMS, not as a sesamoid bone, and these bones are typically so small, we won't be able to tell that they are involved in a fracture until we get definitive imaging in place. So we just don't have the tools to really go too deep into sesamoid. But I put that on there just as a quick little aside. So you're welcome, all you sports med fans out there. I did that for you. You can see here on the diagram a breakdown of all the different kinds of bones. So we have our irregular bones like our vertebrae. We have a great example of our flat bones would be our rib cage and the bones individually that make up that rib cage. We have another very, very large flat bone, our scapula. And then we have our long bones like our humerus, our tibia and fibula, our radius and ulna, and our femur. Can't forget the femur. And then finally, we get our short bones. Our short bones are typically going to be found in our hands and feet, and they're going to be making up the tarsals, the metatarsals, and the phalanges, and all those good things. Now, we're going to be talking about the types of breaks that we see across these things, but I have found it's much easier for my students to understand the modality in which bones break. If you look at a long bone, a short bone, or a flat bone, you can think of that as being a branch, and specifically a branch that's small enough that you could hold in two hands, and with a little bit of force and pressure, you could break it. Bones that are of a long or short or flat makeup, typically, if they're long enough, will break in one or two places depending on the mechanism of injury and the forces that are exuded on them. Whereas flat bony surfaces like the scapula and the plates that make up our cranium typically break like a plate. So if you were to drop a plate on the floor, it would actually be kind of interesting if it broke clean in half. That's not the way that plates normally break. They normally break into a lot of different pieces and they shatter. And that'll be important later on when we talk about things like crepitus and deformity, because those are two very obvious things that we can look for to determine if there's a fracture in place, but we typically don't see them cross over very often. We don't see a whole lot of crepitus involved with long bone fractures, and we don't see a lot of clean, even breaks with a flat bone like the scapula or with the skull. The flat bone that's kind of the exception that proves the rule is the ribs, and that's because of their flat but long nature. So they tend to break in a more clean fashion. So as I said earlier, bones have the ability to self-heal, and they're actually pretty great at doing it. They have evolved to a point where they can fix themselves once they have started that process, and they will actually form up in a way that's stronger than before. Now, that's not to say that the body is this amazing self-healing machine that doesn't need any assistance. If the bones aren't in the right place and they start to heal, it'll actually create more pain and deformity and loss of function or use further down the line. So that's why it's really important that we effectively determine a bone that needs to be reset versus one that should be splinted in a position of comfort or in a position of movement, and we'll talk about that in a little bit. But let's go back to the nature of that self-healing property of the bone. So when a bone breaks, there is soft tissue swelling and then a blood clot that is sent into the fracture area. Because of the interruption of blood supply, there is a die-off of cells at that injury site. That die-off of cell will cause there to be typically some type of a contusion or hematoma, as well as some discoloration, obviously. And then it starts a cascade effect. Cells that are further away from that fracture will rapidly divide and then form a tissue that heals the fracture and develops into the new bone. So it's important to understand that this is all happening under the skin the moment that that fracture occurs and that blood clot is formed. So fractures for our patients that don't have the ability to normally form clots, whether it be because of medication like a blood thinner or due to some type of anemia or other bleeding disorder, they won't have that ability. So not everyone has that ability to create these new, stronger forms where the bone has broken. It's very important to remember that. Now, We've talked a lot about the bones. Let's talk about the other, lot less important, but less focused on actors in this play that we call musculoskeletal injuries. So we have three kinds of muscles. We've already talked about these. We've got skeletal that are voluntary, smooth that are involuntary, and cardiac that are only found in the heart. Some voluntary muscles would be your bicep or your quadricep or your any muscle that you can flex is considered a voluntary muscle. Involuntary muscle would be the kind that lines your stomach and your intestinal tract. It doesn't need to be flexed to work. It works on its own. And then finally, cardiac is something that is only found in the heart, in the myocardium. These very different muscle types can only be found in certain areas, and they're very well documented. There's not a whole lot of confusion on that. So we can go ahead and shut the door on finding new kinds of muscles just yet, because as of right now, this is what you got. Now, on the other hand, cartilage is nothing like these muscles. Cartilage is a semi-rigid form that helps provide flexible structure to the body. In certain parts of our bones, we really don't want there to be a whole lot of movement. And I get a lot of questions about the type of bony structures that make up our ribs. We do have very hard calcified bony structures in our ribs. But if you think about it, we wouldn't be able to take even larger breaths than normal under stress if the rib cage was rigid and made of bones. Our bones don't flex very well, and that's why those cartilage structures exist, and that's why we have cartilage in the rib cage, to allow for more expansion. It also allows for our body to grow so that we aren't stuck in the same size for the rest of our lives. So that is why that's there. Also, quick side note, for all of those that have taken a CPR class that have had a very gung-ho instructor that say, if you're not breaking ribs, then you're not doing CPR. They're wrong. You're actually breaking mostly cartilage. And if you look at any skeleton, you'll see a very, very big difference between the bony rib structures that wrap around to the vertebral column versus the type of cartilage that is closer to the sternal plate. That all is cartilage, and that's typically what you're feeling crunching when you're doing chest compressions for the first 60 or 90 actual chest compressions. There are going to be ribs that may be broken, not always, but sometimes, so they're not completely wrong. They just don't care to correct themselves and be, formatically correct. So I think it's important that we bring that up. That's why I bring that up. Now, how do we make all these things move together? We use tendons and ligaments. And it's important that we understand the difference between the two, because a lot of students, myself included, have made the error of calling a tendon a ligament or a ligament a tendon and so on and so forth. So let's break it down into a way that's super easy. Tendons allow for movement across the joints, and tendons attach muscle to bone. So the easiest way for you to remember that is MTB, muscle, tendon, bone. Boom. Don't make it any more difficult than that. Ligaments, on the other hand, support joints by attaching these bone ends so that we have a stable range of motion instead of just flopping about and having way too much range. The best way to remember that is bone, ligament, bone, or BLB. So if you are listening, for you to remember where tendons go, it's MTB, muscle, tendon, bone. For you to remember where ligaments go, it's BLB, bone, ligament, bone. Don't forget that. Now, here's a quick diagram of all the different kinds of muscle, cartilage, so on and so forth. And we're really just focusing on the cartilage, but you can see that there are different types. And for all my sports med students out there, we know that there's a difference between striated and non-striated and partially striated muscle. But for EMT, we really don't need to get into that. Just know that skeletal muscle is voluntary, smooth muscle is involuntary, and cardiac muscle is only found in the heart. Duh. So that's what you need to know. Now, in this diagram, we can see a little bit better on where these attachments occur. Now, tendons are always going to be attaching muscle to bone, MTB, right? And ligaments are always going to be attaching bones to other bones. So bone, ligament, bone, BLB. If you ever forget, remember that it's MTB and BLB. You can't screw those two up. You just can't. but this is what it looks like inside. Now, we've done our review and everyone's feeling good and warmed up. Let's start talking about some actual emergency care. Now that we've gone over the anatomy and physiology, we can break into the mechanisms of musculoskeletal injury. We're going to deal with three types of force today. We have direct force, indirect force, and twisting or rotational force. And we'll come back to those, but we need to talk about a couple other things before we get too deep into them. It works well if we have a little bit more of the verbiage down before we start talking about actual injury types. So please make sure that you're taking notes and follow along. Now, a fracture is any type of a break in a bone, whether it's open or closed. We have a couple of very specific injury types, and I wanted to talk about those. First, we have comminuted. Now, a comminuted break or a comminuted fracture is where you have a bone that's broken in several places. This is also commonly referred to as a compound fracture, but for the purposes of the class, we want to use comminuted. Next, we have green stick. This is an incomplete break, and we see this a lot in our pediatric groups. Green stick breaks are just like taking that stick that we talked about earlier, where we try to force it and it breaks in half. Well, this is the kind of stick that is fresh off the tree. It's completely green on the inside. It is a living, well, it was a living branch until you ripped it off the tree like the psychopath that you are. And now as you try to bend it, it's not going to be a clean break. You're going to see little pieces of fiber start to pull away. You're not going to be able to make a clean break. This is due to the general flexibility of pediatric bones because they are still forming. It's not a great thing to have a kid with bones that won't grow with them, and then you just have a tiny little adult that just, looks adorable in suits and runs around telling people what to do. The more that I think about it, I think I want to have a boss that is just a very tiny little man with a really deep voice and a three-piece suit. Anyway, it doesn't matter. Green stick is going to be that incomplete break where we have bony ends that are still somewhat attached. And then we have angulated. This is going to be your most distracting injury when it comes to musculoskeletal injuries. And these angulations will be very, very difficult to ignore. They're painful. They look bad, especially if it's a complete break and we don't have a green stick type of break. We're going to possibly have bone ends that are breaking through the skin. It can be very painful and very scary for your patient, and truthfully, in some of these cases, it can be kind of scary as the provider. So don't let that distracting injury pull you away from what's most important. We still need to check for ABCs. We still need to look for things that will immediately kill our patient, and we can deal with that later. Unless it's something that is cutting off blood flow, a musculoskeletal injury should not be the very first thing that you treat if there are other more life-threatening injuries in place. It's not ABC stands for a bone sticking out of the skin. It's ABCs as in airway, breathing, and circulation. So just keep that in mind. This is a great example of one of those angulated but not really kind of injuries. It's pretty obvious that there is a disassociation between the bones of the lower leg, the tibia and fibula, as well as the bones that make up the ankle and the structure of the foot. So this would be the type of injury that you see that we could definitely call distracting, but unless we have a lack of blood flow to the foot, it really isn't going to be something that we're going to mess around with until we get to our secondary assessment or even until we get our transport started. Again, these kinds of injuries are extremely painful and they are extremely scary for your patient to look at, so it may actually benefit them if you drape a paper sheet over it so they don't have to look at it, and then we can expose it in a way that only we can see it so as not to bother the patient. And before you start to say, well, gosh, Eric, why do I need to make sure that my patient doesn't freak out? Well, I'll tell you, strange person that's asking me questions inside of my head, it's because if our patient is uncomfortable or unhappy or scared, it'll make taking care of them much more difficult. And you should also probably be concerned about, how your patient feels. We're not complete unfeeling monsters here. We do this because we care about people and the way that they feel. So it's important to remember that there's a human aspect of it too, but also if you are a cold robot that's just doing EMS because you want to be around humans, remember that we want to try to eliminate painful situations and scary situations as much as possible, because those things tend to drive up our patients' vital signs, their blood pressure, heart rate, respiratory rate, and that can actually lead them to become more sick down the line. So, some more verbs, some more things. Dislocation, anytime that a joint comes apart. A sprain is anytime that we have stretching and or tearing of ligaments, and a strain is any overstretching or overexertion of muscle. It's important that we break these down because a sprain and a strain, they get constantly confused, and as someone that teaches sports medicine, it definitely is something that you need to know the difference for. But if you're in a pinch and you're trying to explain to the doctor or nurse that your patient may have pulled something, it may not be worth your while to say that they strained versus sprained unless you have a little bit more in-depth training in sports medicine, or you have a little bit more understanding of what those things look like. Now, remember that any type of fracture out in the field is not confirmed until we do imaging. Yes, even the bones that are sticking out of the skin, we'll say, oh yeah, there's a bone sticking out of the skin. That's all fine, but we don't know exactly how bad that fracture is. We really don't know how involved those bony structures are. And until we can get definitive imaging, radiology, so x-rays or MRIs, we can't really see the extent of all the damage. And remember, all these bones are typically going to be surrounded by some type of other soft tissue, whether it be the tendons, the ligaments, the muscles, other cartilage, really anything that we would find inside of our body. And these are sharp, very sharp, pointy ends. To say that these things can tear up all of those structures is a very big understatement. That's one of the biggest causes of injury to these patients when they have fractures. Now, that brings us to splinting. Splinting these extremities will help prevent blood loss as well as help prevent further injury to those soft tissues that surround the bones. That's why splinting is so important. It's not really in our book of tricks to cause the patient more pain, but we also don't want to make their injury any worse. And that is why it's important that we focus on splinting when it's appropriate. And typically, unless the patient has only the fracture that they're concerned about, we're going to want to focus on other aspects of our patient assessment before we start that splinting process. Now, that doesn't mean that we can't start splinting if we have a lot of people on scene. If we have our normal response, and the response where I teach is typically comprised of 2 EMTs on an ambulance and then 3 to 4 providers from the fire department that makes up our ALS response. And at that point, with 6 people on scene, you can have one person that's doing their assessment, another person that is documenting the assessment, 2 other providers that are preparing and splinting any of these injuries, and then you've got 2 more providers that can either be preparing the ambulance, planning on their egress to the hospital, or maybe even reaching out to the hospital to let them know that we're on our way with a XYZ trauma patient. So, assessment. We need to rapidly identify and treat any life-threatening conditions. We need to try not to get too distracted by grotesque wounds or distracting injuries. And always cut or remove their clothing so you can do a complete examination, because if they have a fracture and we're not going to expose that area, we don't know if there is a bone that's sticking out. We don't know if there is some other type of discoloration that would lead us to believe that there's the onset of Compartment Syndrome. We really don't know. We need to make sure that we take the time to do a complete assessment. Now, it is important to remember that a lot of these musculoskeletal injuries are going to happen outdoors. Why are they going to happen outdoors, Eric? Well, that's where people go when they like to get hurt. People get hurt indoors all the time, but you typically aren't going to find people ramping off their quarter pipe inside their living room, and you're usually not going to find people climbing trees that are inside of their kitchen. So remember that if you're outdoors and the environment is not conducive to cutting off that article of clothing, we may want to wait until we get into the back of the ambulance where we can control the climate a little bit better, and then of course offer them a blanket once we cut their clothes off to keep them decent. Okay? Compartment syndrome. This happens as a severe swelling in the extremity as a result of the fracture. The progression follows as this. The fracture or crush injury causes bleeding and swelling in the extremity, and that pressure and swelling becomes so great that the body can no longer perfuse those tissues against that pressure. You're basically strangling all of those tissues by the immense amount of pressure that's being exerted by blood pooling in the injury. These compression injuries will lead to compartment syndrome, and compartment syndrome can be extremely deadly if we don't catch it and if it isn't treated at the hospital. As a BLS provider, we're not going to have much treatment for compartment syndrome as we would in the hospital, and we need to remember that compartment syndrome is an immediate life-threatening injury that needs to be treated and transported immediately to the hospital. And we want to go ahead and support those patients with supplemental oxygen because we have an issue with perfusion, and we also want to give them some of that good old diesel therapy. Put your foot down on that accelerator and push forward. Now, the progression will also lead to backup further in the system, and that may cause there to be increased blood pressure throughout the body. And if that occurs, we have a much higher possibility for stroke, some type of cardiac involvement, or for there to be increased pressure in other parts of the body, like in the brain, where it's not considered compression injuries as much as it is considered an increased amount of pressure that will need to be drained, and that could cause a potential traumatic brain injury or TBI. So, your patient assessment. Look for pain and tenderness, deformity and angulation, crepitus, and we should talk about this real quick. Crepitus feels like there is some type of material under the skin. I think one of the best descriptions I've ever heard is like putting your hand on a big pile of Rice Krispies right on the table. It's that crunchy, kind of granulated feeling that's under the skin. That's usually going to be indicative of there being some type of shattering effect of the bone, and what you're feeling are the bone fragments under the skin. It could be an indication of other soft tissue damage, but typically that's going to be an indicator of a fractured bone that has been shattered, and that'll normally be found in flat bony areas like in the scapula or in the plates that make up our cranium. We're also looking for swelling and bruising, exposed bone ends, those are sharp and pointy, don't touch them, joints that are locked into position and can't be flexed into a different position, any type of nerve or blood vessel compromise, so we have a very obvious lack of pulses distal to the injury, so below the injury, as well as the onset of compartment syndrome. And then we're going to use our 6 P's of assessment. These are the 6 P's of assessment. Pain or tenderness. Pallor, we're looking for pale skin. Paresthesia, that feeling of pins and needles in the body, that feeling of tingling. Pulses that are diminished or absent. Paralysis, or the inability to move the affected limb or the affected part. And finally, pressure, a feeling of immense pressure. Now, if you think about the 6 P's of assessment, think of the last time that you sustained some type of musculoskeletal injury. Bony injury, what am I talking about? The last time that you had some type of musculoskeletal injury, you probably had all of the 6 P's. You had pain. There may have been some pale skin, maybe because you were scared or maybe because of a rapid movement of blood away from the rest of your body to that affected part. Paresthesia, that may or may not have occurred, but there is probably some tingling. You probably did not have a pulse that was diminished or absent, but you could definitely feel a pulsation in that part that was affected. Paralysis, and paralysis is not always going to be involuntary. Paralysis may be, it's so painful for me to move that I cannot and will not move. We can still consider that part of our 6 P's. And then finally, pressure. You'll always have those complaints of immense pressure at the site where the injury occurred. So I want you now to think about it. Does your patient's musculoskeletal injuries add up to a serious trauma or a serious multiple traumatic injury type? Or is this isolated? Do they have a broken arm, or do they have bilateral fractures of the radius and ulna? Do they have a broken femur, or do they have a comminuted fracture of the femur? And does your patient have circulation, sensation, and motor function, or CSM, in that suspected fracture or dislocation? And remember, we're always checking distal or further away from the site of the injury. It wouldn't be appropriate for us to check for a brachial pulse on a patient that has a fracture to their radius or ulna. We would want to go lower to the radius itself. Now, patient care, always take your standard precautions, perform your primary, and then during your secondary assessment, apply a cervical collar if you suspect spinal injury, and then consider at that point applying some type of a rigid, inflatable, traction, or folding or conforming type splint, I should say, to that extremity. These splints should be something where we can splint in the position of function, or if that's impossible, the position of most comfort. We also want to cover any open wounds with sterile dressings, and we want to note those in our narrative and our patient care report, or PCR. So, splinting. There are advantages to splinting, and they are numerous. These are the advantages. It minimizes the movement of broken bone ends and disrupted joints. It helps prevent additional injuries to soft tissues, being the nerves, arteries, veins, muscles, tendons, ligaments, so on and so forth. It will usually decrease pain, because increased pain is with increased movement, so decreased pain equals decreased movement, so on and so forth. It'll help minimize blood loss, and it can prevent a closed fracture from becoming an open fracture. And I'd like to just talk about a call that I ran many years ago now, where we had an individual that had an open tib-fib fracture, tibia-fibula fracture, from a motorcycle accident. I read my partner's report after. It made me laugh. He said the mechanism of injury was motorcycle rider versus the ground. Hard. We ended up having to rewrite that narrative. They didn't accept that as the chief complaint. This individual had an open fracture of the tib-fib, and I spent the entirety of the transport holding that leg in place so that it didn't cause further damage. It was very difficult. It took a lot of effort from me, and it wasn't that long of a transport. We were only going about 5 or 6 miles, but you know, when you are literally holding two ends of your patient's lower extremity in your hands, you're just scared of any little bump in the road, and boy, the patient felt every bump in the road. Unfortunately, because of the extent of his injuries, we couldn't effectively splint it, and because we were so close, and at that time I was working on a BLS ambulance with other crews, the paramedic that was in charge of the call decided that that was the best way for us to transport them. And, you know, looking back, I would have to say that I agree. Splinting that would have been extremely difficult. Where I work, we carried air splints and rigid splints, and those bone ends probably would have popped the air splint, and it wouldn't have been very comfortable or really advisable to put it in a rigid splint, because it would not effectively conform to those broken bone ends. So hopefully that'll provide you a little bit of insight into some of the weird things that we find out in the field, and how we have to use critical thinking, and, you know, how we have to use our best deductive ability to figure out what will help our patient the most in that moment. So, realignment of deformed extremities is something that is taught at the national registry level, but depending on where you work, it may not be indicated as a BLS provider. So just bear that in mind. Always, as I always say, follow your local agency protocols. Don't go off of what you heard on a PowerPoint on some random YouTube channel that you found on the internets. So, realignment of deformed extremities. It assists in restoring effective circulation, and it helps us fit to the splint. And possibly, if not realigned, the splint may be ineffective. It may cause increased pain. It may cause further injury, and it could involve some of the vasculature, the veins and the arteries, and it can cause undue bleeding. So, let's talk a little bit about realignment. This picture is obviously a stage picture, and what you can see here are two providers that are providing support as well as very mild, gentle guidance for traction to realign a broken bone end. These realignments can be somewhat dangerous, so be very cautious of if and when you do it. And it's always best to remember that if there is blood flow to that distal part of the extremity, realignment probably is not within your best within your best interest or the best interest of your patient. And that increased pain may be momentary, but if we are realigning an area that's already being effectively perfused without realignment, we're actually just increasing the risk to our patient. So it may not be worthwhile. But again, the National Registry is different and the application is different wherever you work. So follow your protocols. I'm going to say it again, follow your protocols. Now, here are the ways that you should, if you're allowed to, realign extremities in the field with your partner. One EMT will grasp the distal extremity while their partner places one hand above and below the injury site. So you need to make sure that the injury site is in between your hands if you're the one that is going to be doing the realignment. The partner, the one that is holding their hands in between each side, will support the first EMT, who will pull gentle traction manually in the direction of the long axis of the extremity. That's a very long way of saying pulling it in the direction that it would be fully extended. So if you were realigning if you were realigning an injury to the humerus, you would pull the arm as if it was fully extended and it was holding itself out as if to show the range of motion in a linear plane. If there's no resistance, then maintain that gentle traction until the extremity is properly aligned and splinted. If you do feel resistance, or if your patient starts to pull back, that's a pretty good indicator that it's not going to happen, and you can fight them all day long. All that you're going to end up doing is causing them further injury, and it's not going to end up benefiting you or the patient or the call in general. You're going to end up looking like the crazy EMT that doesn't know what they're doing. So again, check for those distal pulses. And if they don't have distal pulses and you and your EMT partner are not able to realignment, it may be time to go ahead and get ALS on board so that they can effectively medicate the patient for pain and then help with that realignment. And that's only if your local protocols allow you to do that. So again, for the third time, what is the third or fourth time? Follow your protocols. Now, more often than not, EMTs are going to be able to splint all day long. There's really nothing that they can't splint. They're not allowed to do crazy wackadoo splints. They have pretty clear guidelines on what they can and cannot use, but splinting is really the skill of a very well-seasoned EMT, and effective splinting is something that can be difficult to do when you have a scared or hurt individual. And believe me, every time that you have a broken bone, your patient will at the very least be in some amount of pain. They won't be walking up saying, do you see this thing? It's just hanging there. I don't even care. They came to you for a reason. They called 911. They want you to fix it. So we have three types of splints that are regularly available on EMS units. We have rigid splints, we have formable splints, and then we have traction splints. We also have other types of splints like vacuum splints, air splints, and more readily conforming splints, but we'll talk about that in a little. Time to break down these splints. We're going to go from top left, and then we'll go top to bottom and left to right. The orange splint is known as a vacuum splint, and it operates a little bit differently than that air mattress that you blew up once and then subsequently shoved under the bed, never to be seen again. That pump acts as a reverse of that same air mattress pump because it pulls air out of the splint, and inside are the little tiny foam balls that you find inside of a beanbag. And what it actually will do is conform to the affected extremity. This can be used on all extremities, and it can be used to, even with larger ones, create a more stable platform for hip fractures and for dislocations. Down below that, the medieval looking torture device and its counterpart all the way to the right that we're going to talk about is known as a traction splint. Specifically, what we're looking at is the hair traction splint, or H-A-R-E traction splint. Now, if you've been in EMS for a while, you already know what's coming up next. This is for closed, simple, mid-shaft femur fractures. Yes, we've all heard it about 1,000,000 times. Now you've heard it 1,000,001. These closed, simple, mid-shaft femur fractures are going to be what you commonly see when it comes to a femur fracture, and what this device does is actually pulls those two bone ends apart, and we'll talk about that in a little bit. Right there in the center, you see our good old friend, the rigid backboard. Gotta say, we have drastically moved away from our use of these backboards, but they still do have a place in immobilization and splinting for injuries. And we do even occasionally use them for patients that have spinal injuries, but much less than we used to. Top right, yellow, what you're looking at there is a giant air splint. That would be rolled out, and then that would be inflated with air. So it's basically operating in the exact opposite way of that vacuum splint, and it's a lot closer to that inflatable mattress that, again, you've shoved under your bed and never, ever, 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 ever looked at again. Down below that, those gross-looking orange Kit Kats are rigid splints, and those are rigid padded splints. Typically what we see in the services that are around the area where I teach, we have a little bit different take on them. They're made out of cardboard and exposed foam, but they effectively do the same thing. The splint itself is made out of cardboard, and it has a very minimal amount of padding so that we're not putting, bone directly on cardboard. We will still want to pad the voids with some type of padding material, whether that be towels or sheets or whatever our service carries, but that is in the very essence of the word a rigid splint. It will not conform, it will not change shape, and we can do a little bit different things to size it up for our patient appropriately, but aside from that, it's not going to move. And then all the way on the right, we have another one of those torture devices. That's another femur fracture device. That's another device that will effectively pull traction, and that's called a Sager, or S-A-G-E-R, Sager splint. We in the agencies around here typically use the hair traction splint, but I've worked for local agencies that carry both the traction and the hair. And we'll talk a little bit about why those devices are different when we go into our skills videos, so be sure to check those out. Now, some strategies for splinting. Care for any life-threatening problems first, and then expose the injury site. We want to see what we're dealing with. You should immediately assess the distal pulses for circulation, sensation, and motor function before we do anything else, because if there's an issue with that, that presents an immediate life-threatening issue for circulation. We want to align the long bone to an anatomical position, so as if the patient was standing or laying in the anatomic position. And we want to make sure that we don't push protruding bones back into place. We are simply letting them rest where they are. Immobilize both the injury site and then the adjacent joints. So this is for long bones. If you have an injury to the joint, you're going to splint above and below the site of that injury. For broken bones, we want to immobilize the joint that is above and below that site. Now, apply your splint before you move the patient if it's possible, and always pad the voids. Padding the voids, again, can be done with towels, blankets. You can even use the clothing of your patient if it benefits the response, to make sure that they are secure in that space. If you can stick your fingers in between your splint and your patient's extremity, and there's nothing in between those things, that needs to be padded as best as possible. We should also remember that padding shouldn't cover the injury site, because we still need to assess it for CSM, and we want to make sure that there's no massive changes in color. Now, there are some hazards of splinting. It's not the most dangerous thing that we do, but it can be if we do it improperly. First of all, we don't want to splint our patient to death. We definitely don't want to prioritize splinting over dealing with any type of life-threatening condition. And this is where we get into the concept of a distracting injury. A bone that is at an angle is very distracting, but it doesn't mean that that needs to be fixed immediately unless there is a circulatory issue. And even at that point, it's a circulatory issue that we may need to come back to, because we still need to do our head to toe. So take your time, Be methodical in the way that you go about your patient assessment. Do it the same way every time. And try to focus on the things that you know will kill your patient fast. Airway, breathing, circulation. Now, another hazard of splinting is one that is too tight or too loose. One that's too tight will actually compress soft tissues and, as we already know, can cause an issue where we could actually artificially create some type of compartment syndrome. Sorry, I lost my train of thought there, but I'm at the point where I don't want to start over the videos anymore. I just want to get through so that you guys can get these as quickly as possible. Too tight can cause compartment syndrome, and now we're artificially making our patient much, much worse. We are closing off perfusion to that area, so the injury will take much longer to heal. And we're actually cutting off blood flow to our patient's extremities, which could potentially, if left untreated, could lead them to lose the extremity. Now, too loose will allow for too much movement, and that could cause additional soft tissue or vascular involvement in that injury, and it can cause a lot of problems down the line. So make sure that it's not too tight or too loose. We should always ask our patient, is this comfortable for you? Is this too tight? Is this too loose? And we want to assess for CSM. Now, as the provider, if your patient says that something is too tight, the moment that you start putting your hands on something, they may not be a reliable source for what's too tight or too loose, but you can always go back to skin pallor and CSM, circulation, sensation, and motor function. And we also want to make sure that we don't splint in the deformed position unless that is absolutely the only thing that we can do. Position of comfort is not nearly as important as position of function, and we probably would be benefit by understanding that if we splint in the position of the fracture, we are simply making the patient worse, but in a stable position. It's not going to benefit our patient long term. So make sure that if you are splinting in a deformed position, it's because alignment is not in your protocol, it's not in your patient's best interest, or you've tried and it was so painful that your patient began to pull away and you were concerned about further injury because you didn't have enough personnel on scene. Also remember that if you're in that position, it may be beneficial to get ALS on scene so that they can medicate and then more effectively splint. Always take appropriate standard precautions. Especially if this is open, we may need to consider the use of gowns, goggles, face masks, and the like, but always gloves. And we always want to make sure that the area that's being splinted is exposed. There are very few cases in which it would be unacceptable or inappropriate for us to expose that area, and those would really be environmental concerns. And that being said, once you're in the back of the ambulance, you should be able to go ahead and expose those areas. Really, the only other time is if the clothing is very intertwined with the injury, and we would risk doing more actual damage by trying to cut it off than just leaving it in place as is. We also want to make sure that we manually stabilize the injury site. So remember that splinting an injury is not a one-person job. It requires more than one set of hands typically. Now, what we're looking at here is a provider that is providing some type of manual stabilization. Because this is a staged image, it is difficult for us to tell what the actual injury is, but we can probably assume that it is either to the elbow or to the humerus or to a portion of the radius or ulna, but it looks like they have an injury to the elbow, okay? And that would make sense if we're talking about injuries to joints, okay? So as we assess our patient before we splint, we need to assess for CSM, as we talked about, circulation, sensation, and motor function. And we also want to try to realign if the injury is deformed or if the distal extremity is cyanotic, meaning that it's bluish in color or pale, or if it's pulseless. And again, for the 1000th time, follow your local protocols. As you can see here, we're looking at what appears to be a skin turgor test, and what they're doing is they are assessing the circulation, sensation, and motor function of the injury site, or of the distal part of the extremity from the injury. Before we apply the splint, we want to measure it and then adjust it, cut it down however we need to do, and then move it into position. It may also benefit us to measure to the unaffected side because that will probably be much less painful to our patient. And we can also make sure that it is the right length, the right width, and at the right angle so that when we apply it to the injured side, we move it as little as possible. We want to apply and secure the splint to immobilize the injury and the adjacent joints. And then, of course, once we're done, we need to reassess CSM distal to that injury. And I'm going to make a quick note. Anytime that you immobilize or restrict movement, it doesn't matter if we're talking about placing your patient on a backboard, if you are placing your patient in a splint, or if you're placing your patient in 4-point restraints. Anytime that we restrict movement for whatever reason, we need to assess CSM before, if possible, and always after application. Because if we are doing something to immobilize an extremity, then we can possibly restrict blood flow and cause an issue with perfusion distal to the point of where that extremity is being immobilized. It's very important to remember that any restriction of movement can cause there to be a lack of perfusion, and that can cause a problem with ABC, specifically with circulation. What you can see here is it appears that our patient has some type of an injury to their elbow because they are splinting the long bone structures above and below the elbow, and what they're using is a conforming splint known as a SAM splint. That's S-A-M, SAM splint. And what that is a very small aluminum splint that's padded on both sides. It's typically going to be yellow and blue in color, and it can be conformed to your heart's desire. So you can be as crafty as you want. It looks what they've done here is that they have done a splint that incorporates the angulature of the elbow in a position of comfort and also has a crossbar for support in between the humerus and the radius ulna. So this would be a pretty involved splint. I'm not sure that I'm crafty enough to make this, but you know, if you're really creative and you like doing this stuff, and of course if you have time, then go ahead and start making these when you get on scene, I suppose. I've always found that the simple route is usually best. This seems like it would take a long time to create, but who knows? Every single response that you go on is your responsibility. So go ahead and do what you feel is best for your patient, especially if it's something that you've done before. I probably wouldn't wake up in the middle of the night with a fever dream for a splint and try to do it on my next patient. I'd probably want to try it out on someone that, you know, isn't hurt or sick before I went and pulled the trigger on it. Also, you can see that the patient is assessing that radial pulse with their 2 fingers, and you can tell that it's the radial pulse because they're checking on the side of the thumb, as we've talked about before. And they've also applied a sling and swath, and we're going to talk about sling and swath in just a moment. Now, these splints that we've been talking about so far have been fairly simple in design. They are designed to rigidly immobilize in a way that does not allow for movement. And as I've said before, at least locally, we really do encourage our EMTs not to move the extremity more than it needs to be, and we really want to avoid having them do any type of reduction in the field or any type of realignment of a deformed bone. But there is one very specific fracture in which our EMTs are absolutely encouraged and really have a very specific set of tools to realign a deformed fracture, and that's in a closed, simple mid-shaft femur fracture, and we will utilize what's known as a traction splint. This will counteract the muscle spasms, it will greatly reduce pain, and it will allow us to make sure that those bone ends aren't touching one another or going past one another and causing further pain and underlying soft muscle damage or soft tissue damage. Also remember that we have our femoral artery, or femoral, however you'd like to cut that up, the artery that runs along the femur, and we really don't want that to get involved because if we go ahead and lacerate that, we could have a very, very bad situation on our hands. So we have 2 different types of traction splints. We have bipolar and unipolar. We're going to talk about both of those in a little bit more depth in just a moment. So remember that the amount of traction that's applied should be roughly 10% of the patient's body weight. We shouldn't exceed 10 pounds. And really, only on the Sager are we going to be able to determine the amount of traction that's being pulled in pounds. On our hair traction splint, we're actually going to be pulling until the patient states that there is relief, or until the point where we can see that the extremities are the same length. The affected limb is the same length as the unaffected limb. So, with your traction splint, take standard precautions, and if it's possible, expose the area to be splinted. You need to expose the area because if you are looking at their leg and you can see that there's a massive deformity, because unless you're carrying an x-ray on your ambulance, you're just not going to know, you need to assess for the presence of this femur fracture. The signs and symptoms of a femur fracture are pretty simple. You would see shortening of the affected limb, extreme amounts of pain. Typically, there will be external rotation, meaning that the affected limb will be rotated towards the lateral side, and the unaffected limb will be sitting in the anatomic position with the foot stretched outwards with the toe pointing up. And you'll probably see that there's some deformity in the middle of the shaft. Now, I don't need you to go and measure from the knee to the extremity, or to the fracture, and then from the fracture to the pelvis. If it looks like it's in the middle, it's in the middle. You're fine. Go ahead and manually stabilize the leg and have your partner or yourself pull manual traction. I will say this actually does take a fair amount of effort, and you're going to need to hold it there for probably at least 2 to 5 minutes. So make sure that you're in a good position. Typically, unless you are in a very messy or wet environment, it may be best for you to actually sit down. But if you're crouched, make sure that your knees aren't going to lock up on you and cause another problem further down the line. Okay. Assess CSM that's distal to the injury, and then adjust your splint to the proper length on the uninjured leg. Then position it under the injured side. You're going to apply the proximal securing device, then the distal securing device, apply manual traction, and then the other straps will go in place. Now, this sounds like a pretty rough and fast way of going through it, and it is. We're going to be doing some videos to show you how to apply a traction splint appropriately, and you can follow those links below. Now that we have all the straps and we have traction being pulled, we need to reevaluate the proximal and distal securing devices. So make sure that the ischial strap and the ankle strap are in fact secure and in place, and then reassess CSM distal to the injury, and secure the patient's torso to and the traction splint itself to a long spine board to immobilize the hip and to prevent movement of the splint. Remember, if you're in an area that is not here, it may call for other types of immobilization, or it may have other recommendations on how to immobilize your patient altogether. Here locally, we're able to utilize a backboard, a scoop stretcher, a breakaway flat. We can even use a Stokes basket here. Whatever the case may be, we can immobilize our patient in that. The thing that we want to remember is that this patient probably shouldn't be going on the mattress surface of the gurney with this alone, because there will be too much movement of the hip. We want to put them on a rigid surface. All right, so we can see here that we have our two providers that are assessing the patient for a possible femur fracture. They have exposed the site effectively. They've also removed the skates because they're going to need to go ahead and assess for CSM before and after they apply the splint. And they've also very intelligently applied high flow oxygen to the patient. You can see the non-rebreather mask on the patient. Now, I will say in this picture, it looks like they're treating the player on the ice, and I might refrain from doing that because you're going to have some pretty extreme issues with traction yourself, and you may want to consider removing them from that surface and taking them off into either the area where the Zamboni enters and exits into one of the entrance or exits areas, or perhaps laying out a surface that you can work on and then transferring your patient onto that dry surface, whether it be some type of rubber matting or a blanket that you can work quickly on, because eventually that blanket will become saturated. Now you can see this provider is providing manual traction. She's pulling the patient's leg in the anatomically correct position, and she's pulling with some pressure. Now, if you think that 10 to 15 pounds doesn't sound like much, it really is not until you consider that you are pulling in a very awkward position, typically in a crouched or seated position, and you're trying to hold on in a way that doesn't reduce blood flow, and you're also trying not to hurt your patient. They've had a pretty extreme amount of force that's been exerted on their upper leg. There's a pretty decent chance that there's been some force that was exerted on the rest of their body as well. So we don't want to hurt them. And especially on this surface, on the ice, we don't want to pull them because that would, in fact, cause them to be in more pain. We would actually just be basically dragging them around the ice. Now our provider is measuring the hair traction splint to the unaffected leg. At this point, what we're trying to do is put that ratchet device down at the very end. And by ratchet, I mean literally it is a ratcheting device, not, a ratchet device as in, like that's ratchet. Anyway, so we've got our hair traction splint being measured. We're getting it all sized up. And then we're going to go ahead and tighten everything down and then move over to the affected limb. Now that we're over on the affected limb and we've attached the straps appropriately, and again, please watch my skills video on this so that you can see this being done in action with actual providers as opposed to just doing it by listening. We're applying the straps and we're making sure that we don't apply any of these straps directly over the site of the injury because that can cause there to be more damage, and we're also obscuring that site that we need to constantly assess. Alrighty, moving on to emergency care for specific injuries. Shoulder girdle injuries. When you're doing your patient assessment, you're looking for pain in the shoulder, any type of shoulder that is dropped or drooping lower than the other shoulder, and any type of severe blow or any type of severe amount of force or pressure that's exerted on the back over the scapula. You should assess for distal CSM, or circulation, sensation, and motor function, and use the sling and swath. That sling and swath is another skills video that we'll do to show you how to apply that, but it's a triangle bandage as well as roller gauze used to create a sling, and the swath, that roller gauze, is used to secure the patient's affected limb to their front. That's where it would anatomically sit in a 90-degree or higher angle as we are securing it. If there's any evidence of anterior dislocation of the head of the humerus, place a pillow between the patient's arm and chest and don't attempt to straighten or reduce. And by reduce, we mean relocate that humerus into the socket. It's a very delicate procedure that can be done very quickly by a trained professional, and we just don't train you to do that here. Once we're done putting all this in place, we want to reassess distal circulation, sensation, and motor function and move forward. Pelvic injuries are something that we see on a regular basis. This is your little old lady falls down and cracks her hip. Pelvic injuries are going to result in extreme amounts of pain in the pelvis, hips, groin, or back. And there will be pain when you apply pressure that's applied to those iliac crests. So I want you to go back to the PowerPoint that we talked about the other day, chapter 27. We talked about applying equal pressure on either side of the rib cage, as well as applying pressure directly on the sternum in a maneuver known as a barrel hoop. We will do a very similar maneuver on the pelvic girdle, and what we're trying to do is assess for stability in the pelvic girdle by pressing inward on either side. So on the left and right, we're pushing in with our hands on the pelvis. So that would be that space in between the belly and the top of the thighs. And then we also want to press downwards, and we're basically pressing down on that bone that exists right there in between the belly and the top of the thighs. If the patient can take that kind of pressure, and it shouldn't be extreme, we're not trying to do a push-up off of our patient, we're trying to just apply some pressure. If they can take that, there's probably very little chance that there is a pelvic fracture or a hip fracture in place. So if they can take that, then the barrel hoop would be negative. If that does result in pain, then the barrel hoop test would be positive, and we need to go ahead and assess for stability of the rest of the pelvis. Also, we can do a motor function test by having them lift their legs, and we'll just have them lift them maybe an inch or two off of the ground where they are lying to see if they can do that. If they're able to take that kind of pressure, then there's very little chance that they have a hip fracture or a pelvic fracture. However, some people, especially our geriatric groups, they tend to not expose their level of pain. They tend to, I don't want to say lie, but they tend to be less than straightforward about the amount of pain that they're in. They don't want to be a burden. And the fact that they have called you is evidence enough that they were in some sort of pain, but they may not be forthright with you. And again, it's just because they don't want to burden other people. It's a very common affect of our geriatric population. So try to urge them to be as honest with you as possible and remind them that you're just there to make sure that they're okay. Also, we can practice with lateral rotation of the foot, rotating the foot left and right, as it were, and we don't need to lift off of the bed or off the ground for us to do that. They can do that in a position where they are supine on the ground. Some other things that we should be looking out for is unexplained pressure in the bladder or bleeding from the urethra, rectum, or vaginal opening. Those would be very specific injuries to the pelvic region and probably to the genitals as well. So there may be pelvic involvement. With these patients, we want to try to move our patient as little as possible. That is absolutely important to remember. The less movement that we can get away with, the better. We also want to determine that there is equal CSM in both sides, that we have pedal pulses on top of the feet in both sides. And we can also look for we can also check for a popliteal pulse or on the back of the knee. But remember, those are two very difficult sites to assess for pulse, and you may not be successful. So look for other signs of reduced perfusion, discoloration, pale, cool to the touch. Those would be the types of things that we would expect to see if the patient had reduced blood flow or a lack of blood flow to the extremity. Don't just go off of, oh no, they don't have a pulse on their foot. Well, to be honest, a lot of people have a difficult time getting that. So remember, check for everything. Also, we want to try to straighten their lower limbs into an anatomical position, but do the very best that you can to not increase the amount of pain that they're in. If they are in a better position with their legs at an angle, at a 90-degree angle, then you may want to consider transporting in that position. We don't have to force their legs down to transport them. Also, we want to stabilize their lower limbs and always assume that there are spinal injuries. If it was drastic enough force to hurt what is basically the connection between the upper and lower body, then we can pretty safely assume that there are spinal injuries as well. Also, we want to reassess distal CSM after we move them and put them into their normal position. Take care to look for shock and provide high concentrated oxygen if necessary. Transport your patient as soon as possible and then monitor their vital signs. We do have very specific tools for dealing with pelvic injuries, but they may not be available at your agency. So we have a device known as we have a treatment modality known as a pelvic wrap, where we utilize a backboard and a towel or blanket to effectively secure them to that backboard. We can use the commercially available devices, and you'll find that there are some departments and some agencies that actually recommend utilizing a KED or Kendrick extrication device in the inverse direction. Instead of going up and around the back, the torso, and under the arms, we're actually going to put it on upside down and use those same straps that would normally go around the abdomen and the torso to go around the hips, with the component that would go up and behind the head going in between the patient's legs. But we'll talk about some alternative uses for tools later. We're going to apply these to patients that have pelvic deformity or pelvic instability, whether or not there are signs of shock present. So this is a commercially available device that sits up and around and reduces all extraneous movement of the patient's pelvic site. What's more common is a pelvic wrap. And what you see here is the preparation for a pelvic wrap. So let's look at a couple of these pictures so that you can see what's going on. Also, please note, the patient has already been placed in a cervical collar, and the patient is also already on supplemental oxygen with what appears to be a non-rebreather mask. I do apologize for the quality of the picture. It's a little difficult to tell from here. So when we have our patient situated on the backboard, the sheet should be placed underneath them. And we want to make sure that we have enough room on either side to effectively wrap them. By taking the two ends, wrapping them around each other as if we are making a knot and then securing it down, we can go ahead and confirm that we are pulling in some way, shape, or form some pressure up against those fractured sites. We'll also take that sheet and we'll tuck it in and tie it, but that is something that your training officers will show you how to do based on the equipment that they carry. Now, hip dislocation is different than a pelvic fracture, but we do a lot of the same things to take care of it. With your patient assessment, look to see if it's an anterior or posterior hip dislocation, and look for some of the telltale signs. Rotation of the leg inward when the knee is bent, or if the knee is bent. The foot may be loose and unable to flex because of an impinged nerve or due to lack of blood flow. And the patient will often complain of lack of sensation in the limb or those pins and needles from our 6 Ps, that tingling sensation. Go ahead and assess for distal CSM. Move your patient onto the long spine board. Try to immobilize that limb with pillows and blankets, and then secure the patient to the spine board. So again, we're padding the voids here, and we're basically making it so that we can position them in a way that we don't move them in a gross manner. We also want to reassess for distal CSM because at this point we have effectively immobilized our patient, take care for shock, and then transport, monitor vital signs, and then check for nerve and circulation impairment by looking for regular signs of CSM. There is a geriatric note that we should make here. Direct force and twisting forces can cause a hip fracture through a motor vehicle collision, but more often than not, a fall. Now, our geriatric patients are at much higher risk for musculoskeletal injuries because of the gradual degeneration of their bones because of lack of calcium, as well as just the general aging process. These older adults are more susceptible, and as a result, we should have a much higher suspicion for these injuries in our position as an EMT if we have a patient that's complaining of pain in an extremity or pain to a bony structure. For the hip fracture patients, again, make sure that your patient assessment includes the following: localized pain, look for surrounding tissues that are discolored, look for evidence of swelling, and also try to assess for their range of motion and ability to move. So if they're unable to move their limb while they're on their back, or they're unable to stand, we would be considering a possible hip fracture. The foot on the injured side may turn outward, and there may be some shortening, but it won't be nearly as severe with the shortening of the limb as it would be with a femur fracture. But you will most likely see one or two of these things in combination with the presence of a hip fracture, as we've talked about before. Your patient care involves putting a folded blanket between their legs, and then binding their legs together with wide straps or with wide cravats, or using one of the commercially available devices to limit the movement of the hip. Use some thin splints. Boy, that's a mouthful. Say that 5 times fast. Thin splints, thin splints, thin splints, blah, blah, blah. Use thin splints to push cravats or straps under the patient at natural voids and readjust so that they will pass across the chest, the abdomen, and below the belt, below the crotch, above and below the knee, and at the ankle. That's a whole lot of different things that are difficult to explain, so be sure to look for our skills video in the future on how to appropriately splint a hip fracture. As you can see here, this patient has been appropriately splinted to a backboard after what appears to be a hip fracture. You can see that there's a towel in between his legs, and there have been cravats that have been woven in between or above and under the patient's legs, and have also been most likely adhered to the backboard to prevent even further movement. This patient is also on supplemental oxygen, and it would appear that this patient may be unconscious because his hands and wrists appear to be immobilized as well. And that's a very common way to transport a patient that is unconscious or unresponsive, so that their arms don't dangle and get involved in the mechanisms of the gurney, get hung up on doorways or in small hallways, and don't end up getting caught underneath the backboard. As we've talked about before with femoral shaft fracture, this is when we talked about our traction splints, the Hare and the Sager. Do your patient assessment in a very methodical fashion. Look for intense pain. Do look for an open fracture, although an open fracture will be a contraindication of utilizing the traction splint. A contraindication, again, for those that are just joining us for the trauma fun stuff, is anytime that we would absolutely not do something, whereas a indication would be when we would absolutely do something. Also, make sure that the injured limb is showing some external signs of femur fracture, whether that be deformity, swelling, bruising at the site, typically mid-shaft, some type of external shortening, and also external rotation. Care for bleeding, manage shock, provide oxygen, assess for the distal CSM before and after we apply the traction splint, and then appropriately apply that traction splint. Please make a note for peds. When the traction splint is applied, make sure that you use the appropriately sized splint. All splints are not created equal, and we do have different sizes for pediatrics versus adults. So make sure that you have that. If we don't have it, it wouldn't be appropriate to use an adult splint because it may pull far too much traction in terms of poundage. Also, infants and children with fractured femurs also have other injuries to internal organs, and because their structure is so small, it may be easy to overlook that. So just take that into consideration. For knee injuries, do your patient assessment. Look for pain and swelling, pain and tenderness, and then deformity with swelling. Also, always assess for distal CSM before and after we immobilize, and then try to immobilize in a position of comfort, or if it is possible, position in the position of range of motion. Injuries to the tibia or fibula will be very similar. We are assessing for pain and tenderness, swelling, and possible deformity. You can utilize an air-inflated splint, a vacuum splint, or a rigid splint, whatever your little EMT heart desires. And we want to make sure that we immobilize in a way that does not cause increased pain, as well as allows for effective blood flow distal to the site of the injury. We want to immobilize the fracture further if we're utilizing an air-inflated splint or a vacuum splint with a rigid splint, and we want to make sure that that is splinted in a way that we can effectively move our patient. It won't help if we have them splinted off into some strange direction or position, because we won't be able to get them in the ambulance. And then always remember that if we are utilizing these splints, that we want to use an ankle hitch to make sure that the splint isn't just wrapped around the top and bottom. We want to make sure that it's wrapped around the foot as well. Ankle and feet injury. Again, pain and swelling, possible deformity. These are what we're checking for in our patient assessment. In the patient care, look for distal CSM before and after we immobilize the site, stabilize and lift the limb. Place cravats, which are thin pieces of sheets or other material under the ankle, and then tie the pillow around the ankle so that it doesn't move. It may be more effective and appropriate for you to simply put a pillow underneath there, and if you are working at an agency that has sheets that are able to be lifted with the patient, make sure that you have additional personnel on scene or at the hospital to move them over to the bed if you're not going to take the time to affix the pillow to the ankle. This is what an ankle or foot injury splint would look like utilizing a pillow, and you can see that the providers have taken the time to also take a blanket and fold it up several times and place that under, so that they can get about 20 to 30 degrees of elevation under the patient's foot. That will help with eventual healing, and it falls into the sports medicine ideals of rest, ice, compression, and elevation. With your patient care, make sure that, again, after we elevate the second pillow with a blanket, we want to reassess distal CSM, care for shock, and then apply ice packs as needed or as your patient can accept. With forearm, wrist, and hand injuries, we're going to be looking for very obvious signs: deformity and tenderness, swelling, or extreme pain at the site, as well as any other types of signs like dislocated fingers. So forearm, wrist, and hand are very similar to the rest. What we see here is that the providers have splinted an injured finger, and what they've done here is, in the absence of a splint, they've taken the injured digit, the finger that is injured, and they have affixed it, they have taped it in place to a non-injured finger. This is a great way for us to deal with fractures to fingers and toes, most likely to fingers, but it won't really be able to be utilized in other areas. It's not appropriate for us to tape two legs together and call it a day. That's just barbaric, and it'll make you look like you don't know what you're doing, so don't do that. You can also see that utilizing a tongue depressor, we can immobilize and splint a single digit. And what we want to do here, in difference to checking for CSM where there's a pulse, we're going to look for skin signs as well as capillary refill. And the way that they've done it in this picture actually will not allow you to check for cap refill. So they didn't do the greatest job on this one, but it does look like it's a very effective splint, although we can't check for CSM, so boo. Now, it's time for the chapter review. Thank God. It's an hour and 20 minutes in. Let's riggedy-diggity do this. Bones bleed. Fractures cause blood loss within the bone as well as from tissue damage around the bone ends. Serious or multiple fractures can cause shock. Splinting of long bone fractures involves immobilizing the bone ends as well as the adjacent joints. It also involves us assessing and reassessing that site for effectiveness of the splints. If areas are not being perfused, tissues die. Time is tissue. The longer they go without perfusion, the more tissue that will die. Splinting protects the patient from further injury, reduces pain, and helps control bleeding. Duh. You may need to be creative while splinting, but remember, if you don't know how to do it, don't just do something wacky. Make sure that you know how to take this splint and make it so that it fits this type of injury for this type of patient. It's not going to be acceptable for us to play arts and crafts while we're in the middle of a football game on, Friday night. It's just not acceptable. So if you haven't done it before, don't get creative. Try to make sure that you are practicing this outside of the field, outside of patient care time, on someone that actually isn't injured. Also, injuries to bones and joints should be splinted prior to moving the patient, but we don't want to, in quotations, I'm doing this in quotations, so quote, quote, don't splint your patient to death. Don't splint before we treat life-threatening injuries. If your patient has multiple trauma or appears to be in shock or has significant potential for shock, don't waste your time splinting individual fractures. Place your patient on a long spine board, secure the limbs to the board, and then start your transport. Individual fractures can be transported and or can be splinted during transport, but we can't make up for lost time when we are splinting on scene. And truthfully, all that we're doing there is we're taking a longer period of time to get the patient to definitive care. And I'm going to make this argument time and time again. EMTs, paramedics, pre-hospital personnel rarely provide definitive care. Definitive care is that thing that will make the patient better, that will fix the problem that they're having. We just don't do that out in the field, and that's okay. I don't want to start doing field surgery, and neither should you. We're going to take them to the hospital to get them definitive care. So the best tool in your tool belt is always going to be that very special therapy, diesel therapy, baby. Put your foot down and drive. Remember, bones, joints, muscles, cartilage, tendons, and ligaments make up your musculoskeletal system. These provide the body with structure, they store metabolic materials, and they produce red blood cells. The joints are the places where bones articulate to create movement, and our ligaments and cartilage provide the ability for additional movement as well as some form of structure and function. Remember that fractures, dislocations, sprains, and strains are musculoskeletal injuries that are caused by direct force, indirect force, and twisting force. Injuries should be splinted prior to moving the patient unless the patient has more serious injuries or illness going on. A closed extremity injury is one that the skin has not broken. An open extremity injury is one in which the skin has been broken. Pelvic fractures and femoral shaft fractures often indicate more severe internal injuries, and we should make sure that we have an opportunity to expose the site where the pain is being indicated. So look at where your patient is pointing, ask them where the pain is, and expose that site. Of course, make sure that we're doing it in an appropriate setting. The back of the ambulance is a very controllable setting, whereas the side of an ice rink or in the middle of a mall, not as controlled. EMTs must learn specific techniques for immobilizing particular injuries, but at the same time must foster creativity while applying the general rules of splinting. This is a great slide for us to talk about creativity and critical thinking. EMTs are constantly coming up with better ways to do more with less. Now, more than ever, we're seeing EMTs asked to do things that they were never trained to do. They're working in hospitals, whether it be a normal standing hospital or a recently erected field hospital. They're being asked to work in clinics and urgent cares, on ambulances in unfamiliar cities. EMTs are constantly being asked to adjust and adapt to the environment in which they find themselves in. And as a result, they have to be creative. They have to be able to find better ways to do the same job with the same materials. The best compliment that you can ever receive from someone, whether they be a doctor, a nurse, a paramedic, or even a fellow EMT, is, wow, that worked really well. I've never thought of doing it like that. Chances are you learned from someone else who learned from someone else who learned from someone else. But if you are the first person to do it, congratulations. You are at the next level of being an EMT. The very first level is one that has their card and they are learning how to do things the way that the agency tells them to do it, or their company or their class tells them to do it. The next step in EMT and in mastery of becoming, of actually working as an EMT, is learning how to take all those tools and do new things with them and be effective with them. Some questions to consider. As you are assessing your patient, have you fully addressed life threats and maintained your priorities even in the presence of a grossly deformed extremity or a distracting injury? Does your patient have an injury that actually requires splinting, or is it more appropriate for us to leave that injury as is? Does your patient have multiple fractures, multiple trauma, or shock? Does your patient have adequate CSM distal to the musculoskeletal injury? And how are you finding out if that CSM is actually there? Also, should I align the angulated extremity fracture? And when we should and should not realign injured sites. Finally, remember, patients that suffer fractures can be in extreme pain. Pain can cause anxiety and elevated pulse rates, as well as elevated blood pressure and elevated respiratory rates. How can you differentiate between a patient with a rapid pulse and anxiety from pain versus a patient with rapid pulse and anxiety from shock? Go ahead and answer below so that we can get your thoughts on that, and I'll go ahead and reply as soon as I see your comment. Thank you very much for joining us today. It's always a pleasure to reach out to my students, as well as students that are interested in learning a little bit more for EMT or EMR or even sports med. Be sure to like this video if it was helpful for you. Subscribe for more fantastic content, and as always, make sure to reach out to us if you have a question, comment, or correction. This is Eric at the Band-Aid Man OC. Thank you very much for stopping by. Have a good one.